anyway, this hour will be the most fun you can have, possibly, and without a doubt, and still be talking about healthcare data exchange. I guarantee it. So anyway, we'll get going. My name is Jim Benson. I am the CEO of Zen Healthcare IT, and along with me is my co-host. She's also the president and co-founder of Zen along with me. She's the current chair and three-time member of the Carequality Advisory Council, so she obviously knows way more than I do about the national networks. She's a active member of the Trust Exchange work group. She's also a network governance SME. I can't hardly even say it. And she's also a high trust and compliance expert and is a member and guides, along with Derek, our Zen compliance work group that keeps us between the white lines for high trust overall. So welcome, Marilee, as well. Karen Flaties, I always give some credit to because she works very hard behind the scenes in making this work for all of us and make it look easy. Even though I don't make it look easy from time to time. She's the director of marketing here at Zen, and for those things, you folks that see things that have been put out there, Karen's at the heart of all of those. So we appreciate her hard work on that. As I've mentioned at the very top, this is a little different than if you're thinking just a webinar or something that you just sit back and watch. Nah, this is not it. We invite everybody here. It is an open mic type of discussion like you would have, sitting down at any old place and talking with a group of people. We invite prospects. We have our clients that are here. Quite a few of them are clients on the list here today or in attendance today. We also invite vendors and yes, even competitors to join the discussion. We kind of figured that the rising tide lifts all boats here. So please turn on your cameras, your microphone. Do not hesitate to introduce yourself in the chat room here. Overall, open it up. Say hi to folks here. You never know where you'll find somebody that you need to connect with and you make some other relationship, and that's a good thing for all of us. So please do that. I will mention in the housekeeping things, I'm going to do the same sponsorship that I did last week for those of you that were here. It is a big deal to us. We've worked very hard on it. The sponsor is Zen for this one. It is the Zen's integration engine. Insight. See, I can't even say it. It's the monitoring and alerting solution for Mirth-based integration engines. So if you know how to spell Mirth, if you've ever run Mirth, we encourage you to check out the Insight. Free trials are available for it overall, but if you'll find that there are some. This is the tool that we developed in-house to keep our clients running and be alerted of issues before they get out of hand. And if you've ever had walked in on a Monday morning or something only to find that things were down over the weekend, Insight is for you. So please check it out. It's worthwhile. I will also mention to everyone here that we do sponsorships like this. They're at a really good price. They're free. So don't hesitate to reach out and say that you might be interested in having a sponsorship. We'll mention you there to this wonderful group of people. And if you're on this, you're probably paying attention to interoperability. So it's a built-in audience. So we encourage you to do that. Anyway, we'll move on from that. Right there. Last thing is, before I turn it over to Marilee for Interoptics, is I will mention that we do have a lot of these. We've been doing them since the first part of 24 now. So we've got quite a few topics, most of them still relevant that is there. Karen is going to post the link to that. You can go to our new website. It looks much better than the old one. If you haven't been there for a while, please go to it and look for webinars. And you'll find all of the previous ones that we've got there. You can peruse through it, and you'll find some pearls there, if I do say so myself. All right, enough for the housekeeping there at the beginning. Interoptics is what I came up with as a stupid name for what's going on in the news. And Marilee, you added a new one here that's just coming on right now with the FTC. Tell us what's going on with that.
Yeah, this was pretty current news in that announcement came out that the FTC is investigating an EMR, in this case Epic, for antitrust. I don't know that that was on my bingo card this year. Maybe it was on yours. So what do we know? Very little, but we know that they kicked off the investigation. There's currently no specific findings, so things are just getting started. And they do believe there's some aspect of this that has to do with the fact that Epic does, under its customer umbrella, control so much patient information. And probably, potentially spinning out of, multiple lawsuits of people suing other people about access and data exchange and trust. So it will be interesting to watch. And you guys have heard me talk about Brendan Keeler. If you've been on any of these meetings before, if you're interested in any legal matter happening in the health tech space, sign up for Brendan Keeler's blog. He's very good about talking about, what to watch for, what things are going to matter, and how they might apply to, impact the industry overall. The other thing I wanted to call out is that we are approaching conference season, so that's very exciting. I wanted to let you know where Zen's going to be. So both Jim and Marilee, yes, we are unchaining Jim from his desk, and he is traveling with me to the DC area for the Civitas for Health annual meeting, September 21st through 24th, where we'll get to meet and see all of our HIE friends and colleagues. Right after that, in October, we have the Commonwealth Alliance annual meeting in Redwood City, California. I am very excited to be attending that, and I will be on a panel, so they say. So I don't yet really know what I'm going to talk about, but I'll be on a panel there. And then finally, we have what I call the National Network Annual Meeting Tour, where we have a health exchange, we have the Carequality meeting, and we have the TEFCA RCE meeting, all in Lost Pines, Texas, near Austin, so in our backyard. And that is, almost immediately after Commonwealth, October 28th and 29th. And I think actually that's a bit short. There's probably a day missing in there somewhere, maybe the 27th, 28th, and 29th. Anyway, lots of conferences coming up. Jim,
Lots of
I'm going to
fun.
let you go to one.
Yeah, oh yeah, she let me out of my cage. It's an oddity for me, so no telling what you'll get. So you'll want to show up at Civitas just to see that I am actually real.
He's
Um,
real. We're not the
yeah,
same
I
person.
am real. Does anybody have any other conferences or things that are going on here this fall that everybody should know about that we didn't mention? Remember, this is open mic. Don't be bashful. Okay. Well, if you come up with one, throw it in the chat for us. We'd love to make sure that everybody is aware of that. All right, you've endured the first 9 minutes of all this housekeeping stuff. Let's get down to it. Marilee and I work on preparing for this. I know it doesn't look like it, but we actually do. And see, and we get Marilee mentioned Brendan Keeler, who was actually our guest last month. And if you joined us, you know that he he's a wealth of knowledge for a guy who's not an attorney. He's pretty good at a lot of stuff. Anyway, he had a great one. Again, there's a link to it if you want to check it out. But we had such a good time with that, and we were talking a lot about ECW and Epic specifically because he has a lot of huge amount of knowledge on it, and we decided that we wanted to continue that stretch into other EHRs. And we sat back and we thought for a little while, do we know anybody at any EHRs? And we went, oh, yeah, obviously I'm kidding here a little bit because we know a lot of folks at a lot of EHRs, and certainly one is NextGen. We've worked with the folks at NextGen going back to Shelley Raisin days, quite honestly. And Shelley used to burst into Marilee's office and give her things to do,
Homework
homework to do. That's a lot
on
of fun.
Super Bowl weekend.
Yeah. Lots of fun there. So
I still haven't recovered.
we thought about the next gen and obviously Marilee's experience in all these other work groups and what have you. And Marilee jumped up and said, "I know." What'd you say?
I said, absolutely, we should have my friend Daniel Werlin on. Let me get that invite out.
And Daniel was foolish enough to say yes. So
Yes.
another
Uh,
subject. I'm a friend.
yeah, I mean, obviously, I mean, we had our conversation a month ago about Epic and Athena Health. NextGen obviously is a very important, impactful EHR across the country with large numbers of provider groups representing a lot of individual providers. Um, and so the interoperability with NextGen is very important. Exchanging data between the hospital and the ambulatory practices, very important. So we know that because of our relationship with NextGen that spun out of the fact that many of us used to be at Mirth and NextGen acquired Mirth. So we know that they have very robust interoperability capabilities. And so it's super important for us all to understand, what their approach is to interoperability. And so that was really why I said, okay, NextGen needs to be on the list for sure. And then also, I think, and Daniel, you may feel differently than I do on this subject, but I think a lot of people don't know what NextGen is doing in regards specifically to TEFCA strategy. So I just felt like, oh, there's probably going to be some interest in that. Let's let our friend who is the guy. So with that, I would love to go ahead and introduce you finally, Daniel. And by the way, I tend to call Daniel Daniel a lot. He goes by, I think your friends call you Dan.
Usually, you can call me Dan too, Marilyn.
My problem is I have a child named Daniel, and so I'm just programmed to go back and forth between Dan, Danny, Daniel. So I'll avoid Danny. How about that?
Yeah.
So Dan is is the interoperability product manager for NextGen Healthcare. 15 years with NextGen. That's amazing. Definitely a veteran. And importantly, he leads the division that we're here to talk about today, which is the being responsible for developing and maintaining the national network. So Direct, Carequality, the TEFCA networks, as well as some adjacent diagnostic and payer networks, getting to do some fun things like electronic case reporting, and then just, kind of helping guide at NextGen the strategy around the ongoing evolution of interoperability and data privacy. And Dan and I know each other because we served on the Carequality Advisory Council together. And I happened to know that Dan was willing to take on some of the harder challenges that we were wrestling with for several years, which was greatly appreciated. So with that, Dan, welcome.
Welcome.
Thank you.
So that's a long introduction there.
I'm going to turn off my camera, unfortunately, having some bandwidth issues here.
There's always some kind of problem there, but we got you, and everybody's seen your picture on that. Although you did have a beard.
Yeah. It comes and it goes.
It comes and goes. Yeah, beards do that. No, we're certainly glad to have you here. Thank you for indulging us and being a guinea pig for us here to dive in. Marilee, you've got some questions that you threw out here to begin with. I'm going to let you start.
Yeah, I think that 15 years is really interesting, Dan. So we'd love to hear a bit of like, what happened over that 15 years? How did you end up in this particular role?
So many things. So I did start out on the implementation side at NextGen. It was Interop, connecting to HIEs or RIOs as we called them back then. And I did that for a couple of years. But there was an opportunity to move over to product, which I jumped at. I was getting bored with implementation, and I thought product would be more interesting. Broader exposure and have a chance to sort of shape the experience that that both our clients and the internal people were having. All those things. When I was in implementation, who designed this? Surely it could have been done better. So I quickly learned to eat my words, but that was one of the reasons why I wanted to move over to product, to take the sort of the in the trenches experience, and also just sort of to be able to broaden it in the interop domain.
What is the day in the life today, and recently with all of the changes in the national networks and what have you? What are the biggest problems that you face right now?
Um, So, day to day, it really doesn't matter what network you're using. There's, as you noted with the video, there's always some sort of hiccup going on, regardless of the network, regardless of how long that network has been in place. And so, there's always minor troubleshooting, but also trying to take a step back and observe that, is this literally just a hiccup, or is this a trend? Is there something we can do better? Is this worth the investment to make it better, or is it not worth the investment? Do we need to pivot completely? So for better or worse, I do have exposure from the very granular, this client is having this problem today, to the very strategic, oh, they dropped, HTI 27. What are we going to do with that? And USCDI 15, even though we're only supposed to be on 3, trying to think about what's coming next, and how to plan for it, how to position ourselves and partner and whatnot. So it's the full breadth right now.
Yeah.
Yeah, that's really cool. And I know everyone is dying to know about your TEFCA plans, but I think it would be helpful to set the stage a little bit first, because there are a lot of NextGen providers in Carequality today. So maybe if you could set the stage for us, kind of the history of NextGen's national network journey, the Carequality experience, and kind of what has led to the next step to TEFCA.
Sure. Yeah. So we've been Carequality participants since the very beginning. And it was a very successful experience. I think big supporter of sort of Carequality specifically, but also kind of the underlying concept, the underlying vision of Carequality. Once TEFCA rolled around, and then it became clear that people were actually going to do something about it, which took a while. It was sitting in sort of inert legislation for a while before somebody actually started to do something. Initially, we were just sort of waiting to see whether there was going to be traction. But at the end of the day, we need to support our clients, and if there are organizations that our clients want to talk to that are on a specific network, then we're interested in participating in that network. So it really became a no-brainer that we were going to participate in TEFCA. There was some debate, should we become our own QHIN or should we partner with a QHIN? We ultimately decided to partner. And I'm very pleased with that choice. And we initially, we decided to roll it out in phases. One, just sort of to get our sea legs, and again, to see where it was going. TEFCA has been, they release an SOP, and then they release a revised SOP, and then they release another SOP. So we wanted to do it deliberately. And there are legitimate reasons for the evolution of these documents, but we also sort of didn't want to get caught building one thing and then having to build another. And I think it's sort of stable right now for the things that we want to do. So we started by building the responder capability, where NextGen clients are exposed to inbound queries. And what we're finishing up now is the initiator piece, where NextGen clients will be able to initiate those queries. And we made a deliberate choice at the beginning that we would maintain and will maintain a presence in both Carequality and TEFCA for as long as there are people on both networks that our clients want to talk to. Carequality has certainly, made a public choice to align its policies with TEFCA, and Carequality may become a QHIN, it may go away, it may decide to do something else. I have no special insight there. But for as long as they are a relevant player for our clients, we architected our system so that we will be able to participate in both networks, but sort of obscure the complexity for our clients. They'll know where the data is coming from, but the clients will never have to make a choice. Well, should I query Carequality or should I query TEFCA? That we sort of do on their behalf.
Very interesting. One of the follow-up questions that I had, and we've had the discussion with multiple guests here on Interop Workshop, is what defining critical mass. TEFCA is out there. The framework is out there. We've got lots of QHENs at this point to work with, but the adoption and the switch to that is really dependent on attaining critical mass, whatever that is. When enough people have signed up, then it's the obvious choice to go ahead and sign up and participate with it, because that's where all the information is. But until that point, none of the people like me want to spend a lot of extra dollars creating something that isn't going to be there for the next year or 2 years or whatever the case happens to be in it. How does NextGen measure that critical mass that you're talking about? And it sounds like you certainly haven't made the decision that you're going to stay with both until it's obvious to turn one
Yeah,
off.
so we're in a position where we're able to relatively simply hedge our bets and connect to both. So if I were a totally brand new entrant and I had to pick Carequality, TEFCA, or both, that would be a trickier conversation, although I do think things are going in the TEFCA direction. But I'm fortunate in that I don't have to make that choice.
Right.
We had Carequality connectivity. We added TEFCA, or we are in the process of adding TEFCA connectivity, and we have a little magic in the back end to be able to route queries or deduplicate results that come back appropriately, so as not to unnecessarily burden the consumers on our side. But with a little extra effort, we didn't have to make a choice. And that was certainly deliberate on our part.
Fantastic. And just for clarity, I want to make sure that I'm understanding. You, behind the scenes, say, we're going to handle the queries to the multiple networks. And when you get results, you dedupe those results, irrespective of whether it came from the QHEN
yeah. So without going too deep in the weeds, if we send out a query, we will see. If a client sends out a query, to the networks, we will federate that query out to both the Carequality network and the TEFCA network as appropriate. And we anticipate some results may come back just from Carequality. Great. Some results may come back just from TEFCA. Great. Some results may come back from both. And when they come back from both, we have processes in place to pick one over the other so that duplicates don't get shared.
Nice. And I'm going to, you talked about QHENs, but you didn't mention it. And even though there might be competitors in there, I want you to mention the QHEN, because you said that you really like working with them.
Yeah, so it's not a secret. Our QHEN is No2, who's been an excellent partner and well known in the interop space for many years.
Fantastic, and props to them, and you both, because obviously it is working quite well. And again,
I think I saw Matt Becker on the call, but he left before I could give him a shout
out. we'll send him the recording.
Yeah.
That's good.
I love it.
But that's good.
Well, we've been kind of teasing the topic of NextGen and TEFCA, and you're obviously working with No2 as your QHEN. But can you tell us, where are you? I'm a NextGen provider. I want to get on TEFCA. What do I do?
Earlier I was alluding to TEFCA and the RCE changing their SOPs, changing the requirements, and that's one of the things that we were sort of waiting to stabilize, and specifically it has to do with what's called entrant vetting. So if you want to be part of the network, you have to be vetted. One of the concerns on the Carequality side, real or imagined, and there was certainly some truth to it, was that perhaps some organizations were participating in Carequality that maybe shouldn't have, or maybe should have gotten a closer look. And the folks over at TEFCA certainly they took that to heart. And I by no means implying, that Carequality was being loose with the rules, but I think TEFCA sort of took a lot of learnings from what Carequality had experienced over the course of a decade, and so they have very tight, or at least tighter, vetting rules for how you get in. And just over the course of the last few weeks, it's tightened up. And it looks to be, this is going to be the steady state for a while. So now we can start to build to that. Now we can start to put together what are both development work on our side, but also just, procedural work in terms of how, what we would ask of a client to provide so we can best position them to enter. So what we do need to provide is, certain basic things that sort of substantiate that you are a HIPAA covered entity that are providing treatment. So of course there's multiple use cases, but the one that we're most concerned with right now is treatment, because that's the golden ticket. You submit a treatment request, everybody's got to answer you. And similarly, IAS, patient requests, individual access requests, you have to respond. So if someone's going to query me, and I have to respond, I really want to make sure that they belong in the network. And so now that's all pretty much set out, and we just sort of we're figuring out how to best operationalize it, because entrants, they're going to have to provide, federal identifiers. They're going to have to provide NPIs. They're going to have to provide copies of X12 transactions that substantiate that not only could they theoretically be doing treatment, but they actually are doing treatment. In addition to lots of information about, what's your legal name? What's your DBA? What are all your locations? What's your website? Why don't you have a website? All of that information has to go into that vetting packet. And now that we know what it all is and what the requirements are and the evidence types are, now we're in the process of sort of building that out so that it can be as smooth as possible and not this sort of bespoke approach anytime a client wants to enter, but that it can happen sort of quickly and seamlessly.
Sounded like a lot of overhead for quickly and simply, but it's necessary.
Well, we're hoping, again, to be able to put as much of that in the background, just put this information in and we'll take care of it.
Yeah. And I'm curious, are you finding that, and I realize you're early days in terms of with this, and by the way, kudos to you for waiting until they simplified the vetting process, because I cannot tell you how much time I spent trying to explain path 1, path 2, path 3.
Marilee, that's one of the reasons why I waited, having that conversation with you.
Yes, it was
sounded terrible.
It was daunting. Yes. But do you find that they're asking, like, why do we have to do this? Like, are they pushing back at all, or just scratching their heads?
So I try to sort of anticipate those questions, and when I frame it as when these treatment queries come in for there are certain exceptions, of course, but when treatment queries come in, you have to respond. They have to respond. So we want to make sure, balancing, not making everybody take a polygraph, but on the other hand, having a reasonable sense of security that everybody in here belongs, that they are actually rendering treatment. And that's why they're asking for your data. So if you don't mind, give us a little information to prove to the other people, just like they have to be able to prove to you that they belong in here. And the information that is being requested, it's not super onerous. Sometimes they're like, what is an NPI? And I have to have that conversation. What's an NPI too? But once you get back past some of those things, it's all pretty straightforward. Now, where I have more complicated conversations on a totally different topic is, say, for direct trust, which for various reasons, to get those certificates, you have to have an individual person validated in their personal capacity. So we don't have to do that. And some of these people that, I have to work with, my clients, they're the same people I had to work with direct trust. So I say, don't worry, it's nothing like that. This is easy.
Yeah.
That's a great and kind of contrast, I hadn't even thought of that, but yeah, that's a very good point to make. It's all about trust. It's all about making sure that other people can trust you and you can trust other people. Excellent. Well, one of the things that I know a lot of folks are curious about as we see an influx of a particular EMR into TEFCA-based exchange, and we're super excited to have NextGen providers starting that vetting process and joining and showing up in the provider directory. I'm curious how you're implementing or supporting individual access services. So you did mention how that is one of those required response exchange purposes. And as I'm sure you're aware, there's what I call the Athena Health model, where they just respond in the same way that they respond to a treatment query with a document-based response, and you really can't tell the difference other than what's happening underneath the covers related to the identity token exchange. From NextGen's perspective, how are you looking at IAS? And then we also have, of course, by contrast, the way that Epic is doing it. So I'm just curious what NextGen's strategy is.
Yeah, so that first model is how we're planning on rolling this out. A query, an IAS query in this case, comes in, and we look to find where that patient is, but really, except for the CSP, for the token validation, we treat it just like a treatment query.
Okay, awesome, wonderful. And when someone queries NextGen, I'm assuming they get a CCD back. I think you mentioned the US CDI that you're supporting. And then my question is, are there other document types, or are you guys keep it simple with one document type? Just curious about the variation.
So right now we're just supporting the CCD. I do anticipate we'll be rolling out other document types. Not even going to try to give a date right now. So CCD, you didn't pay me enough. CCD is the baseline. And then we'll certainly be looking to, what other document types would provide value.
Fantastic. Well, I am very happy, and I'm sure there may be other happy people on this call that individual access service providers will, who have done a lot of work to be able to participate in TEFCA, will be able to have it work in a way that, is efficient and safe, trusted, and efficient for everyone.
Yes.
Now, did I miss something? Is IAS currently supported? Is that roadmap? Where are you in the development? Maybe I just phased out there and didn't hear.
Right. So right now we are supporting, we support the, inbound queries, and IAS is part of that.
Got it.
So if a provider's listed, they'll be good for both treatment and IAS response.
Yes. Right.
Yeah. Awesome.
And you're supporting that. It comes in to you and across the nation, you'll find it. How do you, because you've got a lot of implementations.
Right. So we have multiple NextGen implementations. We have a central demographic database that knows where all our patients are. So when a query would come in, the first thing that we do is we check that database. And then that database will tell us, Marilee is over here and over there. And then then we split the query out to those two locations.
Got it. Well, it's more than two, but I won't tell you how many it is. Sorry. Okay. And because I was just looking at our Slack with multiple clients here just the other day, timeframes to respond to those things. Is that an issue for you? Because it is for some of the vendors that we support.
Sure. So time frame is always it's volume. It's all about volume. That's one of the sort of the ongoing challenges, is to be able to build a platform, to be able to build a structure that's performant under these waves of volume.
Yeah.
And so I'll just say it's an ongoing focus of our effort to be able to make sure that we can that we can respond, you know, in an appropriate way to the volume that comes in. And as we all know, it's not smoothed across the day. There are peaks and there are troughs, and to be able to survive at least at a reasonable level, you know, at the highest peaks, is you know, is what I spend a lot of time thinking about.
Yeah. If you're on this call, you know what we're talking about. All of us have experienced it. It's one of the reasons why I was in the Slack with clients that we have just the other day. It's a universal problem. It's lumpy. And you got to be able to support the highs and the lows. And we got to have you know, a reasonable process that when timeliness just can't happen because we all don't have unlimited resources. You know, how does it handle? You know, how is it handled gracefully, and the ability to ultimately get to the destination of providing the information.
Sure. And you know, and to get into the details a little bit, you know, one of the challenges is, so some queries are, I have the patient in front
Oh,
of quote,
may have bandwidth issues again, or is that just me?
tomorrow, and this is an overnight business process. Were you able to hear me?
Can
you hear me?
Rewind about 15 seconds.
Okay. So, so the volume is lumpy, but not only is it lumpy, the needed response time varies as well. So you may have a patient in front of you right now. I need this answer right now. Or this may be some overnight business process querying for all the patients that are coming in tomorrow. And whether that answer comes in 5 seconds, 50 seconds, or 5 hours actually doesn't matter. But since oftentimes, or always, the transaction itself is, and it will time out, there's a challenge there. And that may be something that can be addressed in the future in terms of specifications. You say, I don't need this query answered right now. I just need it answered. We can allocate resources appropriately. But right now, every query must be answered right away before it times out and it's essentially lost for all time.
Yep, we had invested a lot in supporting queued transactions for overnight
Sure.
type of things quite a while ago, and I don't think it's used to the degree that it should be because, like you say, sometimes it's, you know, I need it now. Sometimes I need it for tomorrow morning, and
Right.
Yeah.
we all need to adopt that a little bit better because it's because we can't all have instant response all the time.
It's an excellent point that I actually haven't heard come up in a lot of conversations. So that's a really good one. I'm going to take that one away.
Yeah.
You know, we both have, there are specs for more asynchronous, you know, type queries that exist that are not being used right now. And I think there's also just, you can be a good citizen by following certain protocols. Like Jim said, you know, we will do middle of the night queries for our customers who aren't doing a real-time query really. So they hand it off to us, and then we stage it and we do a real-time query, but we're doing it at 2 a.m, not at 3 p.m. So yeah.
Yeah, exactly. And that's something we're working on as well. Because whether individual systems on the other side can't take the volume, or whether certain unnamed, you know, queue-ins throw rate limits at us, to be able to meter those queries, if they're scheduled queries, as opposed to somebody's clicking a button right now, to be able to meter them. Because again, our guys, you know, doesn't matter whether it shows up in a minute or 5 hours, as long as it's there the next day.
So you opened the door, brother. Okay, so who's doing the rate limiting?
I'm not going to say.
All right. What meeting are we at next together? There might be a cocktail in the future. All right. So one of this is a kind of a detail, but it's one I get asked all the time. So a lot of folks making queries, they may only care about like the last 90 days, or they may have done an initial query and then they're just checking to see if anything has changed when the patient comes in for a follow-up or something. When you get that inbound query, are you respecting the date range that's on the request? Okay, great.
Yeah, we respect the date range. we'll
Yeah, not
default, like
everybody
you don't
does, so I
actually
like
have
to
to
ask.
put in a date range. And if you don't, we'll give you like the last 6 months, I think. But we honor whatever date range you put in.
Okay,
Oh,
fantastic.
yeah.
Um, what kind of things, as I know that your phase two is more focused around the initiating side for your
Yes.
providers under TEFCA. Are there certain things that are on y'all's roadmap in terms of that component, in terms of kind of optimizing the provider's experience?
So say more what you're thinking there.
Well, are you making product changes to make those initiating queries kind of work more effectively, add more value to the providers that are making those queries?
Um, so it's an area of research, I'll say. We don't have something specific that we're sort of ready to build yet, but it's definitely, we want to take this as an opportunity. Okay, now we've got all this data out there, so what are we going to do with it? And there are certain I'll call them just sort of extensions of things we're doing right now. We have automation based on scheduled appointment, so it just runs by itself. Patients coming in tomorrow, the query runs by itself. But you can easily imagine sort of extensions of that. I referred somebody for a specific kind of procedure, haven't heard back. They may have seen somebody, maybe they did, maybe they didn't. I'm not expecting to actually see them for another year, 9 months or whatever, but it would be great if I could get some of that data now, in case there are any red flags, that sort of thing, to be able to queue off of maybe referrals that were made or particular diagnoses that were made. Particularly if I know there are multiple partners in care for this particular patient. One of the things that Carequality and TEFCA is particularly good at is helping to pick up the data that might have gotten lost in transition, or lost in the corner somewhere. It wasn't in that fax that was sent or that direct message that was sent. Maybe people knew about it, maybe people didn't know about it. There was an unexpected admission here or there, but being able to send out those queries sort of open-ended, just to pick up the important pieces of data so that we can have that fuller picture of the patient. And if, for example, I'm a PCP, home base for the client, and maybe have a fuller record than anybody else, to be able to put that data together with that full patient chart, which may lead to certain types of outreach to the patient, or perhaps to the other providers. So that's a kind of a long-winded answer, but adding more kinds of automation, intelligent automation, beyond just a scheduled appointment. That would be number one. And then I would also say, and this is no novelty on our side, everybody is trying to figure out how to do this and if it's actually meaningful. But just throw AI at the answers, to be able. But in seriousness, what has been a challenge since day one of Carequality. Well, I got 5 documents back, and 2 of them are duplicates, and 3 of them overlap slightly. And what am I supposed to do with this? Is there any way that I can just sort of have it intelligently all put together, so I don't have to do that? And not just intelligently put together, but intelligently put together, and I can trust that it did it the right way and it didn't make anything up. So experimenting with that, trying to figure out how best to do that so it's reliable, so it's useful, and adds value, saves time, etc., for our providers.
That sounds really fun. And I think most importantly, really valuable, because to your point, Dan, the good news is the plumbing's working.
Right.
And we're doing exchange at scale, but with that scale comes this usability problem. So
That's right.
yeah,
The fire hose of data, as they like to call it.
Yes, exactly. Now, I see my friend Dr. Holly Miller on the call, and because you do work in the direct world, Dan,
Yes.
I am going to throw a question I didn't prepare you for, so apologies for that. But that's what happens when you accept my invitations. But my question is more around what's happening on the direct side, and specifically, has NextGen been doing any pilots around 360X? Closed loop referrals? Just curious what you know or don't know about that.
So Dr. Miller sent you that question because I wasn't able to make the 360X meeting earlier this
She
morning.
didn't, but I read her mind through the airwaves.
So the short answer is yes. NextGen has built out 360 has built out 360X functionality, and it's sort of been a long haul to sort of like really put it into production. Pulling back again, getting into the weeds a little bit, it's not as easy as, well, I've got 360X, so just send me 360X, a 360X message. The partners on both sides have to know that they're sending messages to each other, and they sort of have to like register those domains internally on both sides so that they know, if I'm sending to you, I will add the 360X package. If I'm receiving from you, I will know to expect it and not, junk it. It's unfortunately not fully plug and play yet. So we have to find two partners that are willing to work with each other. We've had what's the opposite of a near miss, near success? We've had a few near successes where we had, say, an Epic or a Oracle Health hospital and a NextGen clinic that wanted to work with each other. And then one or another thing happened. Somebody got distracted by an upgrade or a merger or something. And so we weren't able to proceed. I am optimistic that we will be able to make that match and make it happen, because 360X, for those of you who aren't aware, it's a technical specification for closed loop referrals for direct messaging. I send you a direct message. You're required to affirmatively accept or decline that referral. And if you have accepted it, you're then further required to let me know what the hell happened with it later on. So that's great. Super important. I'm hoping that eventually the bulk of direct traffic moves to that kind of mechanism.
Fantastic. Dr. Miller, any follow-up abuse, questions you could you could throw? I know that you've got she's looking forward to the
I've been madly typing in the chat. No, Dan is exactly right. It's as you can well imagine, most implementations occur within an organization, and 360X is kind of one of those first implementations that is across organizations. And it's very important. So part of 360X is very prescribed processes around requesting a referral, having the referral completed, and sending back the information. And so as well, you can imagine, I might send a 360X referral request and expect an immediate answer from the organization I sent it to. And so it's very important for the two organizations to get together in advance of implementation while they're testing, and to be able to say, well, we really can't do it immediately. We'll do it within one business day. We'll give you the response if we're accepting or declining that. So it is, as Dan says, very important for the organizations to kind of leadership to meet and agree on some values that they both are going to respect. Beyond that, the technology is pretty much by all the vendors good to go. And we do have a regular pilot meeting, which Dan referenced. It meets every 2 weeks, and most of the vendors that have implemented 360X attend. We do have, it's now at the point of rollout nationally. So we're very proud of that, and greatly looking forward, as Dan references, to our NextGen implementations. We continue to look for client partners that interact with NextGen to be able to do 360X. And Dan, if I left anything out, please feel free to fill in.
No, that's right.
Well, thank you for contributing that, folks. You're seeing right here why we have an open mic policy around here. You get a lot of information, and you get it validated very quickly as well. This is great. Thank you for contributing that. Really good. And if you're a vendor out there and you need to understand more about 360, you just found out who to talk to about it.
Absolutely. If you're a vendor and you have clients, I can say right off the bat, we had our meeting this morning, and one of the vendors was referring to the fact that it has at times taken the organization that they're implementing without 360X to get almost more than a week, almost 2 weeks to get a referral out the door. So imagine if this is a patient who critically needs specialty care. What you end up doing is sending that patient to the emergency department, which is good for no one, and increases our healthcare costs. So please do, if you're a vendor, feel free to contact me regarding 360X. We'd love to have you join us.
Fantastic.
And I think Dr. Miller's highlighting the need for a session specifically on 360X, because I think it's an opportunity to dive into what that workflow really looks like, both at the business level and the technical level. So, Dr. Miller, I think you and I have talked about that. I'll be in touch because
and
it's
will
so
also,
important.
Yeah, it is absolutely important. And equally important, Dan, I don't know if you read between the lines there, but I'd show up next two weeks from now if I were you. Just saying.
Well, first of all, we are getting close to the end of our time. Please, if you have a question for Dan about NextGen, and I think the news that we can all leave with here is that NextGen providers are coming. They're being vetted. They're getting onboarded, and that they're going to be an important addition for both treatment-based exchange and IAS-based exchange under TEFCA. And Dan, we really, really appreciate all the hard work that I know you are doing in order to make this happen, because the footprint that NextGen has in the ambulatory space. And with folks like federally qualified health centers, there's some really important groups to our communities that are represented. So we cannot wait.
I do have one additional question here for you, because we ended up with just a couple of minutes extra here. So you've been doing this for an awfully long time, and you know what's going on right now. Yes, great, Holly. Thank you. The of the problems that you've experienced here recently, and we do have a lot of vendors that either attend the call or certainly listen to the recording after the fact. What would you say to vendors overall to go, guys, stop doing stupid?
You asked me to define stupid.
What is stupid? Yes.
Yeah, I mean, I will say that one of the reasons why I enjoy Interop so much is because, I consider my colleagues to be people that I work with at NextGen, but also at these vendors and sometimes even the competitors often across the country, because Interop only works that way. Whereas if I'm building, like some very important data entry screen for the providers, my colleagues really aren't outside of the company. So it does sound a little cliche, and to an extent it is, but like I really enjoy Interop because I get to work with these people all over the country who are all trying to solve the same problem together, and it only works when we all solve it together. So for the most part, that is indeed what everybody's trying to do. I mean, we compete vigorously, viciously, sometimes even, but Interop only works if you're able to clear at least a certain bar of sort of collegiality and the clinical data wanting to be free. So I really don't have any big complaints at this point.
Okay, well that was really deftly done. That was wonderful. Or I'll do the Key and Peele translator, the Obama translator for what he said there was, don't be a jerk when you're dealing with the EHRs because they're trying to help you. Remember, they're not the enemy. They're just trying to do. You're a Dixie cup, they're a Dixie cup. We're all trying to tie the string together and make the whole thing work. So don't be a jerk. Did I get that right, Dan?
Yeah, that's pretty
Okay,
close.
fair enough. That's great. Okay, Marilee, it's 55 after. We always end on time, but we rarely have. Dan really did a fantastic job, better than some of the folks that we've had, going on and on too long. Covered a lot of territory. We've got 5 minutes. Marilee, do you have anything else, or are we going to give 3 or 4 minutes back to everybody?
Well, I'll leave Dan with one last ability to think a little further down the road. So we talked about treatment, we talked about individual access services. There are these other TEFCA optional
Yes.
exchange purposes. Anything that your providers are kind of asking for or that you're personally excited about in those optional use cases?
I am most of my, brain's bandwidth right now is focused on getting these things live. I am spending, I am thinking about the other use cases, obviously, payers, if they're able to sort of fully enter this area, which they never were able to do in Carequality, that's a huge difference. So something, I'm watching very closely and having conversations about, and, we'll evaluate it, as we see how that plays out. But that's a very interesting one. There's also, billing, healthcare operations, billing for other sorts of things, not just, payers retrieving data for the patients that they covered, but other kinds of operations. And also, we know what's waiting in the wings is, retrieving data for research opportunities, and whether it's, for lack of a better word, I'll call it like, public research, or whether it's pharma company research. There's a lot of data out there, but they're certainly trying to monetize it. So why shouldn't we? And just sort of figuring out how that all works in a reasonable way, where you can still get, reasonable value out of it. So everybody's thinking the same thing. Everybody's trying to figure out how can we do this the right way, where it's the data is treated, safely and with respect, but we can still do something productive with it. And and if there's money involved, where does the money go?
Right.
I think you summed up the challenges and the opportunities.
Yes.
For optional exchange purposes, for
Right.
sure. Well, thank you so much for joining us, Dan, and
Yes.
and Dr. Miller. It was a bonus to have you here to be able to get 360X rolled into the conversation, and to everyone else who joined us. We really appreciate it, and we'll be getting the next event scheduled soon. And we look forward to seeing you on the next month's Interop Workshop.
Yes, and I just posted in the Slack room for not the Slack room, the chat room here, as Karen did, I think, as well. There's to sign up for the next one. Like I said, you can't have more fun and still be talking about healthcare data exchange than right here on Interop Workshop. Thank you, everybody. We'll see you next month.